Yeah, you can share.
Has it popped up?
Yep. Yeah.
Yeah.
Okay. Just a second. So, a good evening and a warm welcome to everybody. We are back with another edition this Sunday, and today we'll be having a session on orthopedics taken by Dr. Kiana and Dr. Jaya. So, I think Dr. Kiana, few of you all might know her. She's from the MBBS batch of 2012 and has completed her MS Ortho from Father Muller's and currently works as a junior clinical fellow in trauma and orthopedics at Norfolk and Norwich University Hospital, NHS. We warmly welcome her to this session. We also have Dr. Jaya, who will be joining us shortly. She has completed her MS Ortho from St. John's, and she currently works as an international training fellow in pediatric trauma and orthopedics at Royal Manchester Children's Hospital. We're very privileged to have such accomplished and knowledgeable speakers with us today, and I kindly request you to make it as interactive as possible so we can get the most out of these sessions. A few reminders. Please keep yourself muted while the speakers are speaking. And if you have a doubt, please feel free to raise your hands or type your queries in the chat box. We will address them as quickly as possible. And also a feedback form will be shared in the chat box as well as in the WhatsApp group. Please fill it before leaving the meeting. Thank you. Now over to Dr. Kiana.
Thanks, Tara. I had done a session last year on trauma, which I think has been recorded from what I've understood. So this is just to cover a lot of what we call cold orthopedics. Like that's what today is about. We're just trying to cover the basics on outpatient stuff, on the stuff that people will come to any clinic for, and stuff that a lot of people might just get stumped with, not knowing what to treat with, or how to contribute to patient care at that point. So we're just going to cover those bits, nothing fancy. It is going to be a little more didactic. I do want whoever is interested, though, anyone who is interested in interacting, if you could just do the whole raise a hand thing, then we'll involve you in discussion, because I think all of you all have read theory at some point or the other. This is not to revise your theory at all. This is just to kind of give you the practical points on what to do with a patient. So I'm just asking that anyone interested raise a hand, and we'll involve you in a very interactive way. And trust me, it's not going to be hostile at all. Yeah, okay. So I'm Kiana. I'm from the batch of 2012. That photo is really old because that's when I graduated in MBBS. What we're going to cover today with back pain is taking a relevant history, okay, and what points you need to cover, how to get a differential diagnosis from your history, when you examine, how to do a focused examination that will help you map the level of the lesion. So when we talk about the spine, there are various levels, various nerve roots, and you're trying to, in your mind, using your history and examination, focus down onto where the problem might actually be. Then we'll talk about management and what you can do at your level. Okay, so I'm not saying that you should admit like patients that have like cauda equina syndrome and stuff, because those are the ones that you need to know, you need to refer. But when it comes to management early on with back pain, how you can make a difference, how you can teach people physiotherapy exercises and the kind of medications that would be safe in those patients. So just briefly looking at anatomy, right? We've got, so if you can see my cursor, so basically these are your vertebral bodies, all right? These are the discs in between them. The cord is posterior to the bodies. So the spinal cord comes here. You've got various layers from your skin onwards. So it's important for you to understand what is there between you and the cord and the disc. All right. So you've got your skin, your subcutaneous fat, you've got the paraspinal muscles that insert onto the spinous processes. You've also got various ligaments. So this would be your, and I'll tell you one thing, orthopedics is very straightforward in terms of naming things. All right. This is above the spinous processes, so supraspinous ligament. This is in between them, so it's an interspinous ligament. You've got over here underneath that your ligamentum flavum. Okay, the reason it's called that is because it's yellow because of the amount of elastin in it. So it's called ligamentum plainum, and it's a very thick ligament. And you've got your spinal cord here. Okay, then you've got a series of ligaments on either side as well over here, but we're not going to get into that. That's not particularly relevant. The one thing you need to understand is that the disc is anterior to the cord. All right. And the reason that's important, right? So like this area over here is anterior and this over here is posterior. All right. So when you know that the cord is, the cord is over here, you know that when the disc goes back, it's hitting the anterior aspect. So that's why when you're doing a focused examination, you're going to check your crude touch and motor movements, and you're going to check pain. You're not going to take out a tuning fork and start looking at proprioception and all of that. That's for the physicians to do. So when you take a history, right? Has anyone raised a hand about interacting? No. Okay. Right. So when we talk about history, we're talking about the most common complaint in orthopedics is still going to be pain. Doesn't matter where the pain is. It's going to be knee pain, back pain, neck pain, but pain. So you have to now pull out as much information about this pain as possible. Where is the pain? Is it in the lower back? Is it in the middle of the back where the thoracic spine is? Is it in the neck? If it is in the lower back, does it radiate anywhere? And is it going to the legs? Is the leg pain more than the back pain? So these are all things that you do need to cover. When you talk about, how the pain started, some of them will give you very like vague descriptions about it. If it is something that's been more recent, say within the past 2 weeks or so, you can ask them, what were you doing at that time? Because some people, they may lift a heavy object and that could suddenly cause a strain on the intervertebral disc and cause an acute disc prolapse. All right. So you ask them, did you lift anything? Were you getting up from squatting position all of a sudden, which is a big sign of what we call spondylolysis and even instability in the joints, the facet joints in between the vertebra. I'll just show you a picture of the facet joint. So these are your facet joints over here. All right, in between where the articulations happen, they are synovial joints, just for your understanding, because those can get very arthritic. All right. So, when someone's getting up from squatting position, and most of them do squat when they go to the loo, you have to also think that maybe there is arthritis over there, or there is some form of instability at those joints. All right. So, history of trauma is important. If someone has fallen from a height, most commonly the thoracolumbar junction is affected. If it's a mid-back pain, you have to also consider the possibility of tuberculosis and malignancy, because those areas are more vascular, and the blood supply of them being rich then makes it easy for bacteria or mets to seed in there. All right. Then we've got, the type of pain. So a lot of it is very spasmodic. Okay. So they'll say it's like a cramping pain. They may tell you, they will let you know whether it is in the midline or if it's on either side. Either side is usually the paraspinal spasm, which is a protective thing. And we'll get into what the spasm signifies in the slides coming ahead. Where does it radiate to? So is it going to the front of the thigh, the back of the thigh? Is it going all the way down to the toes or not? All of these are significant, and I'll tell you how we map the lesion using that. And what makes it better, what makes it worse. So look, all of you already know about like this whole Socrates format. It's the first thing you learn when you enter the hospital. It's literally the first thing when you are in second MBBS, when you enter the hospital and you open your MacLeod or whichever book everyone's using now. It's the first thing you will read about is how to figure out pain based on this. So stick to that, stick to the basics, because using that you'd be able to take things forward. even the character of the pain, right? So like whether it is like a shooting type of pain, because neuralgic pain is very different to any other type of pain, and they will tell you, like, they'll use very, very like cute English words in the middle of all of either the Kannada or the Hindi or whatever wherever you are. They will say, that it's like current or a shock, or so they also have an idea that this is very, very abnormal for them. Age is important, because if you're diagnosing somebody very, very young with this, it could be because of either instability at a younger age. So spondylolysis is quite common among them. Elderly people think of a degenerative process as well. So either degeneration in the joints between, like we talked about, the facet joints, disc degeneration, and what you need to look for in those patients. So past medical and surgical history is really important. Quite recently, I had to evaluate a patient for cauda equina syndrome. This was a few days ago, and it turns out she also has glove and stocking paresthesia from being a type 2 diabetic on insulin. So understand that neuropathy being there is also potentially problematic. You have to take into account that not all, you can always have a patient that has a mixed picture, basically. All right. So a person can have both problems at the same time. Even when it comes to bladder function and bowel function, the autonomic nervous system has a very large part to play. So taking this type of history, finding out whether the diabetes is actually under control or not, is really important. Um, yeah. Um, I think someone's mic is on. I'm not sure. Just check, guys, if anyone's mic is on, just mute it. Yeah, thank you. So, yeah, then even surgical history wise, have they had any procedures done, any nerve root injections? Have they been referred for anything in the past? Have they been exposed to tuberculosis? And have they undergone treatment for it? Because pot spine is still very, very prevalent in India. We still treat it in most medical colleges, including John's. Yeah, then when it comes to personal and family history. So I think getting a differential diagnosis without having tunnel vision is really hard. Okay, so when someone says back pain, you have to literally think of every retroperitoneal structure that could be causing this. Okay, you have to ask about alcohol intake, because you don't want to be missing acute on chronic pancreatitis. You do have to take a gynecological history, because a lot of people with mid-cyclical pain, your middle schmerz, even people who have been having, like, if you ask them, does your pain come around the time of menstruation, and they actually sit and they think about it, and they let you know that, yeah, actually it does, then you already know that it's dysmenorrheic. Okay, so I'm saying that I'm not trying to like say that, pin it on another problem. Okay, but I'm saying keep an open mind, so that you understand that back pain is more multifactorial. It's not as simple as saying that, oh, yeah, it's probably a gynae issue, or it's probably like renal colic. But ask, so like, do you have burning when you pass urine? Have you been having this pain early on in the morning? Is it have you ever had to go and get, like, wake up early in the morning and go get injections for pain because of this? Because we've all been there. We've all been in St. John's EMED. The first thing that you wake up to in the morning is someone with ureteric colic. So rule out all retroperitoneal causes as well. Okay, because if there's something else that could be contributing, while you treat one thing, try to assess for the other stuff and treat the other stuff as well. We talk about tingling, numbness, and weakness, right? So tingling and numbness are very, very like different concepts. Okay, numbness is when you cannot feel something, which is what we mark a 0 on 2 for. So when you grade sensation in any spine pathology, you're grading it on 2. All right, 2 being normal, your regular sensation. 1 being you can feel something, but it doesn't feel normal. It's like paresthesia, tingling, that type of stuff. And 0 being absolute numbness, where you cannot feel something. So Please remember, tingling and numbness are two different things. Don't ask both together. I would ask them separately, because otherwise you will confuse the patient into thinking that they're both the same thing. Motor weakness is a big red flag, so please be aware of that. If someone comes in there, if someone comes in even with like a foot drop, you need to be aware of it. You cannot miss these kind of things. We'll talk about claudication. I will show you a table shortly on what differentiates neurogenic and vascular claudication, because I've realized that I didn't fully understand it till I was a postgraduate. And I didn't, because we're only taught vascular claudication, because I mean, naturally during MBBS, we all pay more attention to surgery than orthopedics, because orthopedics is 50 marks. I don't know if it's still the same, but knowing that, you do need to be able to differentiate the two. Now, another big big issue that we have is bowel bladder dysfunction. That's the autonomic influence on the bladder as well. These are red flags. These are major red flags. So, and we'll summarize all the red flags at the end as well. Knowing that these are red flags, please don't take these symptoms for granted. Do also, like, I mean, there's also this narrative where, people have been referred as Kodak-Quina syndrome, where you have someone who has had a bout of diarrhea and is a mother of 5 children, all normal deliveries with perineal weakness. So yeah, you have to really measure things out, and that's why having like personal and family history being taken quite thoroughly is important, because not every person with a weak pelvic floor from other causes, who may have, so ask, did you have all normal deliveries? Did you have an episiotomy? Have you had similar episodes like this in the past, every time you've had a episode of diarrhea? So these kind of things are important to talk about. A lot of the elderly women in most villages have had normal deliveries, could have happened at home as well, where they've not really been taught how to do Kegels or like strengthen their perineal floor. Account for everything. A lot of them end up having procedentia and like various other forms of prolapse that you have to also account for when it comes to these symptoms. Prolapse can cause some amount of urinary retention as well. Yeah, when we talk about constitutional symptoms, we're thinking along the lines of malignancy as well as infection. Again, these usually, they can affect any part of the spine. All right, you've got your Batson's plexus of veins that allow free flow because they're valveless, they, from up to down. So you can very well get Mets from like most places. You can have your breast cancer and prostate moving through these venous plexuses and reaching the spine. You can have thyroid cancer. I've seen case of thyroid cancer, lung cancer, renal cell carcinoma as well. So all of these can find their way to the spine, most commonly again in the thoracic spine. Fever, night sweats, again, usually infection, usually tuberculosis is the most common one in India. Abroad, you can also see other forms of suppurative disease. So like you can have like Staph aureus and other things. Looking for deformities. So you will, you can, if you have a child coming in and the mom says, looks a bit odd, her back is looking a bit strange. Remember that if you've got a young girl brought in, women are more commonly affected by scoliosis than men are. The statistic is 10 out of 10 children affected by scoliosis, 9 are women. So if you have a young girl being brought in, the mom saying that her back is looking a bit odd, be vigilant and refer for further evaluation. Yeah, so that's about talking about just history. So the idea of this is you have to develop your differentials. Is it, when you talk about back pain, is it intraperitoneal? Is it extraperitoneal? Is it only confined to, which part of the spine is it confined to? Is it moving down the limbs? If it's from the neck, is it moving down to the hands, from the cervical spine? Those kind of things. So you want to basically narrow down location like that. Yeah, so when we talk about radiation, right, When you talk about a lady coming in and she will actually point to her thighs. She'll be like, it's hurting here. Okay. So she will say the front of the thigh, and she'll point right down to the knees. So that's usually because of root tension on the L2, L3 nerve roots. One very important thing, and I want to stress on this a lot, is when you are assessing a patient over here, we're not going to be talking about the femoral nerve, we're not going to talk about the sciatic nerve, we're not going to talk about the common peroneal nerve, we're not talking about any peripheral nerves. When nerves leave the spine, they leave as nerve roots, okay? And it's all numbered. It's That's why we're talking about mapping. If you think that this is not originating from the back, then yes, then you can definitely go about, checking for peripheral nerve injuries and stuff like that. Like naturally, if someone has had maybe an injury to the elbow, you will think about peripheral nerves. You will not think about the roots, because the injury is not where the roots are. But when you know that you're looking at a back problem with potential radiation to a limb that is supplied by the nerve roots coming from that part of the back, then always think in roots. Okay, if you don't go back from this with any other knowledge, please just remember, when you talk about back, when you talk about the axial skeleton, you are talking only in roots. All right. So we talk about the back of the thigh. It could be involving L4, L5, and S1 nerve roots. So these, if you're talking about low back pain, just remember these many. Okay. I don't need you to know about the ilioinguinal nerves being your L1 and all of those things. I don't need you to know any of that. I just need you to understand these things. If you have a lady who has been squatting for prolonged periods of time, who is complaining of not back pain, but of pain on the outer aspects of the thigh, that's the lateral cutaneous nerve of the thigh being compressed by the inguinal ligament, this is not a spine problem. So if you ever find something like this, remember that not all radiating pains in the lower limbs have to come from the spine. Could be from a nerve like the lateral cutaneous nerve getting compressed. Okay, so yeah, sorry. In this image, the reason I put this in is for you to understand that there is at every level. So here we've got L4 and L5, all right, vertebral bodies, and there's a disc in between. So this is the intervertebral space, all right. So at every space you have, the cord will have an exiting nerve root, and then you have a traversing nerve root, which then will exit at the next level. So here you've got L4 coming out. So remember that for L4 and L5, that particular space, you will have the L4 exiting, the L5 traversing. And then at L5, S1, the L5 will exit and S1 will traverse. And there's a reason that this is important to understand. So when we talk about mapping the lesion, all right, we're talking about, okay, the problem is involving these two nerve roots or three nerve roots. So where can I localize the problem to? So when you are doing your neurological examination, if you find that L4 and L5 are being affected, or L5 and S1 are being affected, you could actually think that, is there a disc protrusion happening very close to the cord where the traversing nerve root is getting affected? Could it be a massive disc where, or like a far lateral disc where L4 is being compressed over here? Could it be the L4 from above? So then you kind of map it down to saying, okay, if L4 and L5 are being affected, the problem could be from L3 right down to S1, anywhere over there. Okay, it's about mapping it. If it's L4 alone, it could be between L3 and L4, or between L4 and L5. If it is L5, it could be between, like over here, like having a paracentral disc over here, or it could be if there was a far lateral disc over here. So it depends. It could be either of these levels usually. Same thing goes for the cervical spine, but I think just for keeping things simple so that we don't, we don't overdo the lecture and bore you guys with too much information too soon, we'll just stick to the lumbar spine. Okay, so And guys, listen, feel free, okay, at any point to just like put questions into the chat box, because I know that a lot of these things can be hard to understand, and not asking everyone to be an ustad at this like by the end of it. But then if you have questions, I think this is just the best time to ask them. All right. So when we talked about aggravating and relieving factors, this could also give you a very good idea of what is causing pain. Is it a disc? Is it instability? Is it arthritis? Is it stenosis? Okay. So when we talk about these, all of these are very different pathologies. I don't want to confuse anybody. When we talk about disc prolapse, intervertebral disc prolapse, it's worse when someone bends forward. Okay. Because what happens is that there is a higher chance of the disc causing more nerve root impingement. When we talk about bending backwards, instability at your facet joints causes a problem. The other thing being that in the elderly, you've got that ligamentum flavum. It's a very thick ligament, and as somebody ages, that ligament becomes more lax. It gets thrown into folds, and those folds then kind of fold into the lumbar canal, and that causes nerve root compression as well. It causes some amount of lumbar canal stenosis, which is basically narrowing the space for the nerve roots. All right. So when we talk about that, a lot of people actually say that when they bend forward, they end up feeling a little better because the folds of your ligamentum flavum then get stretched out, and that increases the amount of space in the canal. But when they bend backwards, those folds become more pronounced. And that's when people feel like their back pain gets worse. So these are all very small nuanced things that we all pick up over time. But if you ask these questions, if you even keep like a list of these questions, you guys can screenshot these things. If you guys want the slides later, I'm happy to give it to you. I have like no qualms when it comes to that, because it's an understanding that asking these questions will kind of give you a differential diagnosis when it comes to an axial skeletal problem. So what spondylolisthesis is, and I think I do have a picture of an X-ray here. When you talk about listhesis, you're basically saying that there's instability that is causing one vertebral body, which you can see over here, to, this is anterolisthesis. So it's slid forward off of S1. So this is L5, and that's S1. And this, because of instability at the facet articulation, this has gone and slid forward. So if you have if you have instability causing that, you can imagine now this is your canal where all of the nerves are, and now the dimensions of it at this juncture have been compromised, right? Because you've now got a narrower canal for your nerves to go through, just because of this malalignment. Okay. So that's listhesis, and you have lysis as well. So lysis is again a form of instability. I don't want to confuse you guys, but if you understand that instability can cause some amount of narrowing of the canal for the cord, and reduces the amount of space for your nerve roots, causing some symptoms, that's enough for me. All right. When a person gets up from sitting and gets pain, like now for example, if a lady is telling you, when I go to the toilet, and you have to ask specifically, are you using an Indian toilet, a ground toilet, or are you using a Western toilet? 90% of them are still using the Indian toilet. So when you ask them to get up from, when they tell you, I'm not able to get up after going to the bathroom because I'm having severe pain, think about instability and a problem at the facet articulation. All right. If it's a very elderly person, it's more likely to be an arthritic thing. All right. And if someone says that while walking downhill, I'm getting increased pain, it's because when you walk downhill, you're actually bending backwards. You're extending your spine to be able to control your center of gravity. Because when you walk downhill, you can't bend forward. And that again is because of your ligamentum flavum causing those folds to happen inside of your lumbar canal. And that's why those same people are more comfortable walking uphill. because it simulates the bending forward movement that will stretch out the ligamentum flavum. So talking about claudication, because I did not fully understand this when I was doing bond, but you need to be able to, you can have a mixture of both as well, but you need to be able to take a history of this. A lot of people with lumbar canal stenosis have neurogenic claudication. They usually have bilateral symptoms, in fact. All right. So if you're able to differentiate, it's important. So when you talk about vascular claudication, they can't walk beyond a certain distance, but with neurogenic claudication, they actually can walk for much longer. For when it comes to vascular claudication, they will basically feel better at rest. But neurogenic claudication, they feel better when the nerves are no longer under tension. So that usually means, like, sitting down, bending, and bending the knees and bending the hips so that the nerve roots aren't being stretched too much. And if you talk about walking uphill, it's worse for vascular claudication, but it doesn't affect people with neurogenic claudication. Because again, it's about having more canal space, right? Because of the ligamentum flavum, like we just discussed. Then naturally you have to check for your skin changes and your pulses in vascular claudication, which will be normal in neurogenic claudication. And you can have motor weakness and sensory abnormalities in neurogenic claudication, but vascular claudication, you can also have sensory abnormalities depending on how severe it is, but it's quite rare. I've not seen it personally. Then when it comes to when it comes to the type of pain, you do have more cramping pain when it comes to vascular claudication, but here we talk about the pain being more like radicular and aching. And it also, the direction in which your pain moves is usually for vascular, because the more distal parts get involved first. So you end up having your pain moving from distal to proximal, whereas for neurogenic, it's the opposite. They feel the radiation of the pain go from proximal to distal. So that's another a big clincher. So like you can pick maybe 3 or 4 of these things that you want to talk to the patient about to understand if they have had claudication, what type it is, and actually ask the other bits, like, do you smoke, any risk factors that could increase their chances of having vascular claudication over neurogenic claudication. But I would say pick a few things. So talking about the pain, because you anyway have to ask a detailed history about the pain. Talking about, walking uphill or even walking up the stairs, if they have stairs in their house. And when it comes to relieving and aggravating factors and how much they're able to walk. So if you just pick up like a few of these things, if you pick up a few of these things and decide which ones you want to ask them, that should be more than enough. So there's different, so a lot of people will, when they enter, so we've reached examination, and when they enter the room, you should be able to see that, if a person is in severe pain, they usually will turn to one side. They'll end up bending their body. It's usually because they've got impingement causing some amount of spasm, and they're trying to relieve it. If it is, so if you can look at these as your exiting nerve roots, all right, and your traversing nerve roots, you wouldn't be able to see, but here you can see these as your exiting nerve roots. If you've got the disc prolapsing on this side of it, the patient will want to bend this way so that they can relieve the nerve root. If the prolapse happens in between the nerve root and the cord over here, which is basically like an axis, if you think of it like a person. So if this is the trunk, that's the, and these are the arms, this is called axillary presentation, and this is called shoulder presentation or deltoid presentation of a disc. So depending on which way they bend, you will have an idea at that particular level what type of prolapse it might be. This is just for your information. It doesn't help too much with making a clinical diagnosis. So if they come in, if they've basically got like long-standing lumbar canal stenosis or something higher up affecting the cord, they can come in with a broad-based gait. because even their proprioception is a bit compromised. Um, if you have a large swelling that you can see over the back, which is not your regular paraspinal spasm swelling, it could be, you can think of a tumor or an abscess or a collection. If and then you have to look for deformities. But I would say most of you won't end up seeing a lot of like younger patients with scoliosis, because they will end up taking those patients into like larger cities for evaluation. But you will see all of these like elderly, like neglected ajis sitting at home, who have severe osteoporosis, who have now developed a kyphotic spine. Um, Gibbous and knuckle, I've personally never seen it myself, if I had to be honest. It's usually a sign of, it's known to have been a sign of severe kyphosis because of tuberculosis and like spine collapse. I don't think people reach this far in this day and age. Having a step palpable at the lumbosacral junction, or having like a furrow on either side, that could be caused because of a little bit of listhesis. So if one vertebra has gone and slid over the other one, you can have like an area where you can actually see a line across. This is not the same as a muffin top, and it is not the same as the line where they tie the sari. Okay, please differentiate all of this. Then when we talk about palpating, right? So check for midline tenderness. If you have midline tenderness, there is a chance that that person may have either an infective pathology or malignancy going on. To know where which part it is, you should hold on to some of these landmarks. Okay, so naturally the most prominent spinous process is at the top over here, and that will be your C7. Okay, as you move down, corresponding to the spine of the scapula, not the angle of the scapula, is T4, and the angle will be T7. And when all of the people who want to do anesthesia, always good to remember that the iliac crest will usually correspond to the L4 L5 interspace. So wherever you're checking, use these as landmarks, and sit and count. There's no shame in counting. People won't mind. When you palpate on either side of the spine and you can feel some amount of spasm, usually if a person has like unilateral symptoms, the spasm will be on that side. Palpating the step at listhesis, usually at the lumbosacral junction, you sometimes can feel like when you're palpating the spinous processes that one is less prominent than the other. So you can actually feel that sometimes. So now we're coming to like nerve root signs. These are quite important. So with the patient in supine position and with the leg straight, you can do a straight leg raising test, or the SLRT. Usually it's not significant if it's something at like 10-20 degrees. That means that that person has just already been in a lot of pain, and you need to sort out initial pain management and then reassess. If you lift beyond a certain point, so usually if it's you're able to lift beyond 60-70 degrees without any problem, that's good. That means that they don't have their root tension. So that means that the roots, the nerve roots are not under tension. When you talk about having a positive SLR, it's usually between, let's say, 30 to below 70. Those are where you would look at it as something that's positive. Then the Lasseguier sign is when you take, just to confirm that it's nerve root and not something else, is when you reach the point where it's painful after raising the leg. You can actually bring the foot down by another 10-20 degrees. And then if you dorsiflex the foot passively and it recreates the same pain, it's because you've recreated the amount of tension that 10 degrees would have given you. So that's there. Sacroiliitis is something that you do have to rule out because it can also cause similar symptoms. So if you put the limb into a figure of 4, so that means that you've got the hip externally rotated, you've got the shin, so you've got the hip externally rotated and the knee bent at 90 degrees, and with one leg resting on the other. if you put a little stress and further try to externally rotate, if they have a little bit of pain, then you can look at that as a positive sign for sacroiliitis, which is an inflammatory pathology. Do an abdominal examination, check the hip joint and check the lumbar canal of petit, because you don't want to miss another problem. If you have a fullness over there that you have missed because you just thought that it was mechanical back pain, that person could actually have like an abscess there or a tumor, and you would have probably written it off. So never have tunnel vision when it comes to these problems, because look, at the end of the day, even for us, even like after being specialized, we all go back and we try to make sure that we don't miss things, because we've all done MBBS at some point or the other, and there's no excuse for not having your basic clinical knowledge across specialties. So please always check the abdomen, check the hip joint, and check for any other potential causes. So when we talk about neurological exam, because we talk mainly about the anterior column, all right, we're looking mainly at fine touch and doing up and taking a pinprick. Now, when I say pinprick, look, please, for God's sake, don't take like a sharp needle and poke people. If you have a very wide bore needle or something which is vaguely sharp, that's fine. Please don't poke people. It's not nice. When we talk about motor, again, look, all of these are very, very simple things. You've done it in medicine and stuff as well, even if you've not done it in orthopedics. When you check for an upper motor neuron lesion versus a lower motor neuron lesion, it's important because the spinal cord is still upper motor. Okay, your the nerve roots leaving the spinal cord are lower motor. All right. So now, if you've got something which is at like T10, T11, it's still probably going to cause some amount of pathology at the level of the spinal cord, which is why, for God's sake, please always check for differentiating between upper motor and neuromotor and lower motor symptoms. When you check for reflexes, if you've got exaggerated reflexes, check for clonus. Just check for ankle clonus. It's still so easy to do. And your differentiating between upper motor and lower motor for lower limbs, use your Babinski's. And for sign, I don't know how many of you see very common see neck pains very commonly, but like I'll show you on video. What we do is we just stabilize the middle phalanx over here. Okay, tell them to leave the entire hand very, very loose. So usually what I do is I tell them, look, just do this and then like relax. Stabilizing this, I just do this, and if you see when you flick the phalanx below, like low, like this, the other fingers also go into spasm. That's a positive Hoffman's. Yeah, and doing a per-rectal exam. Now, in conservative parts of India, a lot of people are not going to be okay with this. All right, so what you need to do is understand, does this person have bowel and bladder involvement in terms of history? If they do, you say that you probably do need to have this examination done. And if they refuse, they refuse. If they have been complaining of perianal numbness and loss of sensation, while wiping or while washing their backsides after using the loo, then these are all very dangerous signs pointing towards Corda-Equina syndrome. Okay, and that is something that requires urgent treatment and decompression of the spine. So I would actually say that don't do it for everybody. If you have someone bilateral lower limb involvement with history of bowel or bladder dysfunction, then please recommend it and explain to them why it needs to be done, and that based off of those findings that there is a high chance that they may need to be referred for further surgery. This is just again me trying to stress on the fact that when we talk about a spine pathology, we're talking mainly about nerve roots. So please don't do a peripheral nerve examination. Like if you ever want to discuss any of these cases, you can always call. But there's no point saying that this person has back pain and then saying, yeah, I checked the radial nerve and I checked the femoral nerve and this and that, because it doesn't matter. We're talking about the spine. We want to know, okay, what levels, what dermatomes and what myotomes are being affected. Do you have L2 involvement, L3 involvement, or do you have L4, 5, S1 involvement? Okay. I also do recommend that, this kind of information, it's very volatile. So I do recommend that a lot of you take printouts of these kind of things. This is all off of Google. This is nothing fancy. I think I took this out of Campbell. It's one of our orthopedic textbooks, but you can just Google it and you will know. If you could take a printout of this and of one more sheet, which is the Asia chart, because I don't expect people who are not really, doing neurological examinations every day to remember the location of every dermatome or every myotome. And yeah, that it's forgivable if you don't remember it, but keep it available in case you have to check it. That's all. So my easy way of doing this is, I know that the groin below the umbilicus is usually, so umbilicus is T10, then I know like T11 and T12 will be just below that, and that the groin area is L1. For me, the sides of the upper thighs are L2, then the anterior aspect of the knee is L3, medial malleolus L4, first web space L5, and lateral malleolus is S1. So this is a very easy way that I use to understand it. Do whatever makes sense to you. Okay, and here when we talk about your myotomes, so the reason I would like that you guys take a photo of this or screenshot it, or take a printout. If you could take a printout of the Asia chart and just stick it into your OPD, it will help, because you can actually check these things over here. So you will know that L2 means hip flexion. So when a person is lying down, you ask them to straight leg raise actively. People who have root tension signs, who are in severe pain, may not be able to do it. So you can put it off to saying that because they were in pain, they weren't able to do it. You can treat their pain and reevaluate them as well. L3 is knee extension. So I just tell people to bend their knees, and then I put my hand around the shin or the ankle and I ask them to kick me away. If they're able to do that, that means that L3 is all right. And ankle dorsiflexion and toe extension is for 4 and 5, and S1 will be plantar flexion. This all has to be graded by your regular MRC grading. Okay, so you have to grade it on 5. I hope everybody over here knows what the MRC grading is. I'm sure you've all passed medicine exams, so you all must know it. But use that because it'll tell you where the weakness is. So now I'll give you an example when it comes to saying that this person has weakness of L5 and S1, okay, or paresthesia in L4, L5, S1. You can actually map it saying that, okay, you know that at the L4, L5 intervertebral disc, the exiting nerve root is L4, the traversing nerve root is L5. And so there's a possibility that you have a disc at that level. And if S1 is also involved, there's a possibility that you have it at 2 levels. And so that will help you map in your mind, okay, it could be at either of these levels. You could also think that if this person has an associated symptom of instability, like getting up from squatting position, making all of these symptoms worse, there might actually be like a degenerative condition influencing this. So they could have a facet joint arthritis that has led to some amount of instability and has narrowed the canal or has caused some amount of nerve root impingement to the exiting nerve root. So like this, now when you've got a map in your head, you'll be able to differentiate, okay, this must be affecting that. So please do this very, very diligently, because figuring out which part is being affected is important. When you are doing a per rectal exam, you have to do 4 very specific things. One is checking sensation. if there is tingling and numbness, which is patchy on either side, you can actually say that that's affecting S4 to S5. All right. When you are doing the per rectal exam, if you have normal resting tone, so everyone over here at some point has had to have done a per rectal exam. So I'm assuming everyone here has done it. So what normal, you probably know what normal feels like after a while. If you feel that there is no tone whatsoever, that is very worrying. If you feel that, and then you should always ask the patient to cough, which shows their involuntary tone, because naturally, whenever anyone coughs, they don't soil themselves normally. They shouldn't soil themselves normally. So, as a consequence of that, ask them to cough and see if you can feel the contraction of the sphincter around your finger. And the other thing would be asking the patient to try to hold on to the finger while you are doing the per rectal exam, and that will then test their voluntary tone. So now you've checked sensation, resting tone, involuntary tone, and voluntary tone. So all of these things should be intact. If any of these are compromised, then it could be something a little more worrying. And if someone already has very good resting tone and you're not able to feel any further contraction, that's probably because they're contracting. So again, I can't emphasize on this more. Please think in dermatomes and myotomes. Okay, so when you're talking about saying L2, it's hip flexion. Okay, you're not looking at knee extension and saying that, oh, the quadriceps are innervated by the femoral nerve, and so I'm checking the femoral nerve. No, you're checking L3 when you're talking about the spine. All right. So that bit is something, again, keep thinking in dermatomes and myotomes when you are talking about the axial skeleton. Cord lesions are upper motor neuron lesions. All right. So if you are getting upper motor neuron signs, you are not talking about something that is distal to L1. You are talking about something that is probably proximal and needs some further evaluation. Rule out other causes always through history, through examination. Always think about what else could be causing a problem. If you find a person has a lot of signs suggestive of tuberculosis, remember that they have every chance to also develop a retroperitoneal collection that is probably tracking along the source. Okay, so just bear these things in mind. Look at the patient as a whole. Don't have tunnel vision about what they could possibly have. It's something that you will only get with practice. Think of warning signs like loss of anal tone, any incontinence, urinary retention, that kind of stuff. So when you talk about incontinence, you have to talk about it in detail. You have to say, do you feel like you've voided completely? Are you able to feel it when you go to the loo? Are you able to initiate urine? And another very, very important thing, which I should have probably mentioned earlier, it is very possible for a person to have prostatic symptoms and low back pain. Please differentiate both of them. Okay, urinary retention happening on and off for a long period of time could very well be because of the prostate, but something where you've got severe low back pain with bilateral radicular symptoms and a person has now developed acute urinary retention, it could be cauda equina syndrome. Okay. So how do you investigate? Please do your routine bloods as baseline if it's possible at your center. Always rule out a UTI. If you have X-ray at your facility, nothing like it. Okay, get AP and lateral views. So it also depends on your radiographer. All right. When I was doing bond, I would get standard AP and lateral views. But when I did my postgrad, I understood the importance of having dynamic views, which are flexion extension views. And that's actually why this is important, because you can have a few degrees of translation further in a person with instability when you are doing flexion extension views. And that will actually help you diagnose instability. You cannot see instability on an MRI, okay, because it's not a dynamic test. So just remember that if you have the ability to get lateral flexion and extension views and you're able to see that in the flexion and the extension views, there's a difference in the amount of translation of one vertebra on top of the other, that's a sign of instability. And if you feel that a person has weakness or anything pointing, and you've been able to map a particular lesion saying, I think there's a problem in the lumbar spine, I think there may be a disc over here causing these symptoms, you can always refer for an MRI, and you can always let me know that you've referred for an MRI. And when you get the MRI images, you can share it with me and we can always discuss it. Um, I'm keeping that very open for everybody because I think it is a skill to read an MRI. I don't think it's easy for everyone to do, but I think that understanding where the problem is always part of understanding what the solution might be, and then we can always help make a plan for the patient accordingly. So this is a concept I learned during postgrad, which I didn't know about when I started treating back pain as a bonder. So there are different stages in disc disease. Okay, so it goes through different phases. What I want you to take away from this is that these can be therefore self-limiting conditions. If a person comes with a recent onset low back pain suggestive of a disc disease, okay, you can actually use conservative methods like pain management, lifestyle modification, rest. These kind of things are very, very powerful. And people can actually heal well without having to need surgery. Not every disc has to be operated upon. And I really want that to be a point that I drive home with you guys, is that not everyone needs surgery. And what you guys do when it comes to counseling patients can make a huge difference on the number of patients who end up needing to be referred for surgery. All right. So when we talk about dysfunction, that's the first stage where you've got your disc. Your disc has got the nucleus pulposus in the center, and it's got like an annulus fibrosis on the outside. So an annular tear is usually like the initial part of a very bad acute disc. Okay, because what it does is it has a somatic innervation which causes a lot of pain, and when the nucleus pulposus herniates out, it causes a chemical response. You can also have synovitis of the facet joints, which is again a very, very formative part of arthritis at the facet joint, and that being a synovial joint is prone to osteoarthritis. So if they don't rest, then they go into some level of instability, and they don't heal too well over time. So the idea is that you want to intervene after the initial dysfunction using conservative methods to make sure that they don't progress into something worse. So the left side is actually something that's been discussed last year, but we're just talking about what you should not give people. So if a person has kidney disease, heart disease, or uncontrolled diabetes and hypertension, please don't give them NSAIDs. You will push them over the edge. Um, Orthopedics is not a life-saving specialty. It is a quality of life specialty. So you don't want to be the reason that you send someone into end-stage renal failure. Okay. Opioids are relatively safe, but don't give them to patients where you are suspecting any form of head injury, because it does lower the seizure threshold for patients. And paracetamol, avoid in liver disease only, where you know that that person, you don't want to be pushing an alcoholic into hepatic encephalopathy. Okay. Now, in India, we have a nice variety of muscle relaxants that are available. It does not necessarily mean you have to give all of them. Just remember when to avoid it. So thiopulchicoside, which is, I think, popularly known as Myoral, avoid it in kidney disease. Avoid chlorzoxazone in hepatic impairment. Um, Diazepam is relatively safe, but has very high addiction potential. So use it sparingly. Okay, if you really, really have to. And neuropathic pain, because now your NSAIDs and opioids are not going to change too much when it comes to neuropathic pain. Pregabalin, 75 mg in the evening for 2 weeks can definitely take the edge off. I find gabapentin to be a little too potent. Here in the UK, they use a lot of it for patients with neuropathic pain and in very high doses. But I think I've seen patients respond in India to pregabalin quite well. So you can give that. You do need to give them a warning, because initially, like for the first couple of days, um, patients may have a little bit of giddiness. So tell them always, please have it after dinner, and to make sure that, right after they have it, to go to bed. So a lot of people have giddiness and nausea associated with it. So just warn them, otherwise they'll never come back. Okay. I know a lot of people use combination drugs that have like amitriptyline and nortriptyline, but I think pregabalin is more than enough. So when we talk about osteoporosis, lot of the elderly patients that you will be seeing will come with a lot of osteoporotic vertebral fractures. We call them insufficiency fractures of the spine. Do start them on supplementation. I'm not asking you to start bisphosphonate therapy on any of these people, but I'm saying give them something. As a population, we are inherently vitamin D deficient. All right, something to keep in mind. And when we talk about what you can do, I think that rehabilitation and lifestyle modifications are very important. So anybody can just check on YouTube for back strengthening exercises. When you talk to a patient who is already in pain, don't talk about exercise first. Give them pain medication. Say, I want you to take this for a few days and I want you to rest. When we talk about rest, it's not that you rest tonight and then you go back to work and you go into the field and then you go back to activities that involve bending and lifting. Please reinforce that the maximum they can do is bed rest, go to the loo and come back. Let them rest for 2 to 3 days, not for a week, just 2 to 3 days. You're not asking for too much. So ask them to rest, let the pain come down, then start back strengthening. So I want you to think of the abdomen, okay, of the spine as like a column, and you've got your back muscles on one side and your abs on the other side. Okay, you have to strengthen both of them so that you've got a strong enough strut on either side. So a lot of people with instability of the spine and a tendency for anterolisthesis, if they do basic ab strengthening exercises, and I'm not saying like you should go and tell like a 60-year-old Aji to go and like start doing crunches. Basic leg lifting exercises, or even lying down flat and asking her to contract her muscles so that the her back just touches the curve of her spine should touch the bed or touch the floor wherever she's doing the exercises. I would say tell them to do the exercises on the floor. Tell Aji, please contract your abs. So show her how to do it. I always used to demonstrate to patients in the OPD, whether it was quadriceps strengthening, back strengthening, show them what to do, make them do it in front of you. Otherwise, they will not do it. Half of the time, they don't want to look ignorant. So they actually just say that they've understood and they go and they don't do anything. And then they come back with the same pain. Show them, make them do it. They'll actually feel a lot more confident after that. So it's about making sure that the small of the back touches the flat surface that they're lying down when they're trying to do ab exercises. And what this does is you can almost think of it like causing an anterior splinting to the spine to prevent the effects of the instability from getting worse. When we talk about lifestyle modifications, I'm saying now if a person has low back pain who is unable to get up from squatting because of instability or because of facet joint arthropathy, there are a lot of pharmacies, like large pharmacies and stuff, where you can actually get these commodes, like where you can actually convert a squatting toilet to a sitting toilet, like almost like a Western toilet, by putting this frame on top of that. So you can recommend that. If a person, this also helps with treating osteoarthritis of the knee to some extent, because it reduces the amount of squatting that they do and takes a lot of strain off of the knee. Other thing is when they get up from lying down, to avoid getting up straight, ask them to turn to one side and using the opposite arm to push themselves off of the bed while putting their legs off of the bed. So it's kind of like if you're if you're lying on your back, you turn to one side, throw your legs off of the bed, and then lift yourself using your hand instead of putting the strain onto the spine. Um, Another thing you can ask them to do is to avoid bending forward to lift up an object or while doing housework, to get a longer jadu. A lot of them bend to do housework. Getting a longer jadu will reduce the amount of bending required. Um, and instead of having to bend down forward, to bend their knees and hips and keep the back straight. So these are small bits of advice which actually really go a long way. And I think that at your level, doing this could actually prevent a lot of patients from needing surgery. So, talking about when would you like to refer? So, I don't think anyone has volunteered for discussion. But if you are talking about when to refer, you have to be looking at your warning signs, the bowel, bladder, and all of that. So, this is what they use for red flag and yellow flag signs in the UK. I think the ones that are very, very relevant for us is when you have an older patient, long-standing problems with deficits. Okay, these things are really, really important. So, if you have someone with deficits, you already know that conservative management, if a person has already lost motor power in that area, you're not going to be able to do too much to help them. So, just refer on when you see any form of focal neurological deficit. Okay. Yeah, sorry. I think I took quite some time and I apologize. I think that it was just about making sure everyone got the hard hitting points. And I'll hand over back to Tara.
Thank you, Kiana. We'll now have a presentation by Dr. Jaya. Do you want to share your slides?
Just a minute. Are the slides visible?
No, not yet.
Okay.
Yeah. It's come.
Hi everyone, I'm Jaya. I'm a PG batch of 2020. I did my MS Ortho from John's and I'm currently working in pediatric ortho here in the UK. So today I will be discussing a few common cases that you will see in the OPD, namely knee pain, shoulder pain, and ankle or foot and ankle pain. How would you go about the signs and symptoms? What investigations should you order, if you should order any investigations? How would you go about treating these patients? And which starts from counseling the patient, prescribing analgesics if required, referring to physiotherapy and understanding and communicating with your physiotherapist what is it that you want from them for that particular patient. And of course, most importantly, when would you refer? So the first case is that of a 68-year-old farmer who presented to your OPD with complaints of chronic dull aching pain over both of his knees, right more than left, which has increased over the past 1 year. He has also noticed a deformity of both his knees, which has worsened over the 1 year. Particularly, he has difficulty in squatting and climbing stairs. When you examine the patient, you notice that there is a fixed flexion deformity of 30 degrees of both the knees and a genu varum deformity. We will come to the differences between genu varum and valgum in the next slide. There is bony tenderness and medial joint line tenderness. The range of movement is between 30 to 90 degrees, which is associated with pain, stiffness, and crepitus. And there is obvious quadriceps wasting. So from this case scenario, it is pretty obvious that it is most probably a degenerative osteoarthritis of the knee. But you need to keep in mind that there can be other causes of knee pain. There can be inflammatory cause of knee pain, which commonly rheumatoid arthritis, can be gouty arthritis. So when you are taking the history from the patient itself, rule out other causes of knee pain. Not every patient who walks into the OPD with knee pain is OA knee. So some things which will help you make the differentiate the patients is what is the age group of the patient, what is the sex of the patient, If the patient is a 55-year-old female who is of normal build, probably she might be having RA. Then you go to your history. You have to elicit specific history from them. Ask them if the pain is worse in the morning or it gets worse with movement. Inflammatory knee pain classically has morning stiffness, and the pain will improve with movement. Ask them if they have any other deformities or any other joint pains, like small joints of hands involved. So that is your history. Coming to the examination bit, if it is an inflammatory cause of knee pain, then they will have sort of a uniform bony tenderness, not just the medial joint line, but the lateral joint line might also be tender. Apart from that, the deformity in OA&E, we see genu varum commonly. In RA&E, there can be a valgus deformity. So coming to varus versus valgus, because this is a point which I used to get confused quite often. So just remember, valgus is knocked knees. What happens in varus is in valgus is that the distal end of the bone goes away from the midline, as you can see here, and you can remember it in terms of the knee at least as valgus is when there's gum holding the knee joint together. And varus, also known as bowed knee, is when the distal end of the bone is towards the midline and there is a rum barrel or a rum bottle keeping the knee joint apart. So what happens in OA knee, here you can see the X-ray as well, is there is a loss of the medial joint space more than the lateral joint space because it is a degenerative condition, because of which you will see a varus deformity in the patient. When you're ordering X-rays for a knee joint pathology, always get weight bearing X-rays. Sometimes if they are supine X-rays, then the loss of joint space is not clearly elicited. And don't look only at the AP view, also look at the lateral view, because in the AP view here, it is quite obvious full blown, maybe Kelvin Lawrence grade 4 ONE of the femorotibial joint. But if you have to take the lateral view because there is a component of your patellofemoral arthritis as well. Take weight bearing X-rays, take two views. Then what are the things that you will see on the X-ray of ONE? There is a mnemonic loss, expanded its loss of medial joint space, osteophytes, subchondral sclerosis, and subchondral cysts. Common grading that you follow is Kellgren-Lawrence classification. I've just put this classification here because in grade 3 and grade 4, in grade 3, you can see moderate joint space reduction, and grade 4, its joint space is greatly reduced with subchondral sclerosis. These are the grades wherein you might have to refer the patient later because the disease has progressed to a point where they will require surgical intervention. So coming to the management of ONE, there is conservative and surgical. When a patient comes to your clinic and you've diagnosed them with ONE, please do not tell them that they need a TKR straight away because the disease can be managed conservatively before that. There are non-pharmacological and pharmacological ways of managing it. Non-pharmacological will include lifestyle modification, physiotherapy, and the use of orthotics. Lifestyle modification: counsel the patient regarding the nature of the disease and the prognosis. If it is an elderly patient and if it is a degenerative joint disease, then it will progress. But you have to also tell them that there are certain things that they can do which will help them to reduce the pain and maybe regain function. A lot of these patients might be obese, so it is very important to stress the importance of weight loss, which will decrease the load on the joint and eventually end up decreasing their pain as well. Modification of daily activities. You have to stress that they have to avoid squatting and use of Indian style toilets. As Kiana mentioned, there are shops where you get seats to convert an Indian style toilet to a Western style toilet. tell them that they'll have to use the ramp instead of stairs wherever possible. And if they are elderly people, then installation of rails whenever possible for support, even within the house, would be helpful. Coming to physiotherapy, so early on during PG, even I used to refer patients to physiotherapy for ONE without really understanding what is it that we want from the physiotherapist. Of course, we want pain relief, which can be done via USG and TENS, but you also have to teach them strengthening and stretching exercises, as the quadricep strengthening exercises, particularly in ONE, really help with pain relief. So I'll just show you a video of the same. Sorry. Just a minute. I'll just load the video and I'll share the screen. Is it visible now, the screen?
Yes, 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 yes.
Okay. Yeah.
Lie on your back with a rolled blanket or towel roll placed under your knee. Tighten the muscle on the front of the thigh and straighten your knee. Hold 3 to 5 seconds. Repeat 10 times.
So as you can see, it's a very easy exercise to perform. I would advise that you show it to the patient in the OPD itself, so that, and stress it that they should do it as much as possible at home. Then slow, sustained passive ROM for about 20 to 30 seconds, which will help to regain some of the movement that they've lost. Then other physiotherapy methods that can be used are proprioception and balance training, if available, with your physiotherapist. And sometimes when you're living in the outskirts of an urban area, they might have aerobic conditioning and aquatic therapy available. Just advise them 30 minutes of moderate intensity walking, of course, after you have prescribed the analgesics and that have taken effect. And aquatic therapy is also known to provide increased sensory input and decreased joint compression. Use of orthotics, you can prescribe unloading braces, which help to relieve the load of the medial compartment. If unloading braces are not available, you can also prescribe a simple knee sleeve. They will provide some pain relief in the mild OA, but it won't really help with the deformity. So importantly, when would you refer the patient? When the patient is having intractable pain. When you prescribe the analgesics, the patient has done his physio, but there is no relief of pain as such. When the patient has a grade 3 or grade 4 OA on the Kellgren-Lawrence scale, when the patient has a debilitating deformity, if the patient has an FFT of about 10 to 15 degrees, and if there is an obvious genovarum or a valgum deformity, these are the cases wherein they will need a surgical procedure. But first, please go ahead and advise them about the importance of conservative treatment, because you will end up you might end up cutting down on the necessity of them having an operation. So we'll move on to the next case. A 58-year-old diabetic homemaker comes to you with complaints of dull aching right shoulder pain, which has started over 1 year and has gradually worsened. The pain is worse with activity, and she is unable to perform her daily activities, fastening her clothes, getting an object from an overhead shelf. There is no history of trauma. On examination, both active and passive ROM are limited, and particularly there is a marked restriction of external rotation and abduction. You did order an X-ray for this patient, but the X-ray was absolutely normal. The joint was pristine. So this is a case of a stiff shoulder. Now, what should your approach to a stiff shoulder be? Remember, there are 4 ends which might contribute to a stiff shoulder. The first end is the neck. That is when the pathology lies in the cervical spine. So the patient will have radicular pain, not dull aching pain, which originates in the neck and is referred to the shoulder. But when you examine the patient, the shoulder's passive range of movements will be painless. The second N is not moving, which is actually your true stiffness. There is reduced passive and active range of movements. And your differential diagnosis in this case will be osteoarthritis of the shoulder joint or a soft tissue contracture, which is frozen shoulder. The third N is near normal movement. That is, the movement might be restricted due to pain. DDs for this will be your cuff tendinopathy or a calcific tendinitis of the shoulder. The fourth N, most importantly, is nasty, which is infection or malignancy. The patient will have unremitting pain and there will be constitutional symptoms. There will be loss of weight, loss of appetite, fever might be present. So whenever a patient comes to you with a painful shoulder or a stiff shoulder, this is the approach that you should follow so that you're ruling out all your other DDs of a shoulder pain as well. Coming to the phases of frozen shoulder, because this is the differential diagnosis in this case, since it's a 58-year-old diabetic homemaker who's having limitation of both active and passive range of movement. So there is freezing stage, there is the frozen stage, and there is the thawing stage. Freezing stage is in the initial 2 to 9 months, during which the patient experiences an insidious onset of pain and there is progressive loss of motion. Next stage is the frozen stage of 4 to 12 months, where the shoulder is stiff with restricted range of movements, but the pain slowly will start resolving. And the third one is the thawing stage, which is 6 to 9 months after the frozen stage, where the pain resolves and the range of motion is slowly regained. What I want you to take away from this is to remember that there are different stages within frozen shoulder itself, and it is a self-remitting disease. It should subside in 2 to 3 years, and your treatment, particularly a conservative treatment that you offer, will depend on which stage of the pathology the patient is in. Aims of treatment, I think this is uniform for all the cases that we're discussing today. Relief of pain, restoration of movement, and to regain function. Treatment of frozen shoulder. Yeah, now you can see that. So there is conservative and surgical. Conservative, diabetic control. A lot of the patients that you will see in the OPD with a frozen shoulder will have uncontrolled diabetes. Their postprandial blood sugars might be somewhere in 350, 400. You need to tell them that the control of diabetes itself will help in the shoulder pain. So what happens pathologically is that in uncontrolled diabetes, there is massive glycosylation which is happening, and all of these products are pro-inflammatory. There is a constant inflammatory cascade which is going on. So no matter what treatment you give to the patient, Because of the inflammation, the pain will not subside. So, medical control of diabetes is very important in these cases. You will prescribe anti inflammatory medications and analgesics like NSAIDs. And then you will go to physiotherapy for pain relief and to encourage passive mobilization. Surgical options are manipulation under anesthesia, in which we are able to break apart the adhesions once the patient is under GA and all the muscles around the joint are relaxed. Or you can go for a capsular release, commonly performed arthroscopically nowadays. But a lot of cases of frozen shoulder can be managed conservatively itself, and they should not go on to the surgical stage. So, for physiotherapy, what are the things that you will prescribe? Interventions for pain relief will be ultrasound, interferential rays, and TENS. Importance of passive mobilization and capsular stretching is to regain that lost passive range of motion. So, this will be prescribed maybe in your frozen phase and your thawing phase when the pain has started to come down and the complaint of the patient is more of stiffness rather than pain. Because if the patient is in pain, then he will not perform these exercises. Common exercises that you can perform are pendulum exercises, wall slide exercises, and assisted movement. I'll just show you a video about how to perform these exercises.
Today we're going to demonstrate 3 exercises that binds the frozen shoulder. Number 1, the pendulum. Standing in a stride position, leaning onto the supportive surface on your good arm and allowing the affected arm to hang freely in front of your body. Rock forwards onto the front leg to allow the arm to move freely forwards and backwards. You can also change movement into circles. It should never be painful. Repeat for 1 minute, 3 times a day. Exercise 2, the wall slide. Stand in front of the wall, using a piece of paper or cloth to glide the hand of the affected arm smoothly up and down the wall. Go only as far as you're comfortable. Repeat 10 times, twice a day. Exercise 3, external rotation stretching with the stick. Sit on the chair, making sure you have space available on either side of your body. Hold the stick between both hands, pressing your affected hand with the palm and the point of the stick. Glide the stick towards the affected side, allowing the hand to move away from your body while the elbow stays close to your side. Hold for 5 seconds, then return to the start position. This exercise should be comfortable. You may feel a stretch in the affected shoulder, but it should never be painful. Repeat 10 times.
So, as you can see, these are very basic exercises that the patient can perform at home. And after you've given the analgesics and once there is control of pain, do encourage the patients to perform these exercises because it speeds up the process and they regain some of their passive lost range of movement. So, when would you refer? Again, frozen shoulder is a self-limiting process. The pathology should subside within 2 to 3 years. And but if you feel that the patient is not improving with all the conservative management that you've given, with the pain relief and with the physiotherapy, then you can refer them to a higher center where they can do manipulation under anesthesia and release all the adhesions. If you are suspecting that there is another cause contributing to his pain apart from the frozen shoulder, the patient might have a frozen shoulder, but he might also have a rotator cuff pathology. So in that case, you will also refer them to a higher center. Third case for today, we have a 36-year-old factory worker who presents to you with complaints of bilateral heel pain. It's been insidious in onset and has worsened over the past 6 months. She described the pain as pins and needles, which starts with the very first step that she takes after a period of rest. It is aggravated by walking and standing for long hours and relieved by rest. She does not have any history of trauma. Important occupational history is that as she is a factory worker, it involves long hours of standing every day. So, in all of these three cases, I have mentioned the occupational history and to an extent the personal and medical history. Why so? Because the patient will come to you with complaints of pain when it is interfering with their day to day life, particularly in India. If anyone is in pain and it is not interfering with their day to day life, we tend to just take a dolo at home and get on with it. But in the first case, it was a farmer who was having knee pain and deformity. So probably he was not able to go about his day to day activities and work in the fields. In the second case, it was a homemaker who had shoulder pain and a stiff shoulder. She would have difficulty getting items off the overhead shelves in a kitchen. In this case, it is a factory worker who is having heel pain. Her job entails that she is on her feet for a very long time. So, because of the heel pain, it might be interfering with her job and her day to day requirements. So, please, when you're taking a history, do ask them how is it affecting their job and their personal life. On examining this patient, you were able to elicit tenderness over the heel, which is corresponding to the calcaneum. There is a component of flat foot, and the windlass test is positive. So, what is a windlass test? You perform it with the patient standing, with the foot rested on the ground, but with the metatarso MTP joint and the toes free of a support. You perform passive dorsiflexion of the first MTP joint, which will stretch the plantar fascia and reproduces the pain. So the plantar fascia, it originates from the medial tubercle of the calcaneum, and it will get attached onto the head of the first metatarsal. When you're performing this windlass test, what is happening is that you're further stretching the plantar fascia, which is causing the pain to be reproduced in the patient. Diagnosis in this case is that of a plantar fasciitis. Investigations that you would do. So, since plantar fasciitis is a disease of the soft tissue, you will it can be elicited on ultrasound, but before that, do an X-ray. Look for provocative factors such as a calcaneal spur. Calcaneal spur is right here on the edge of the calcaneum because it might contribute to the heel pain. Other factors that the patient has, such as a flat foot, that will also contribute to the heel pain. But don't go ahead with only one diagnosis in your mind. Gouty arthritis also sometimes presents with heel pain. So just to rule it out, do a serum uric acid. Treatment, again, this is a self-limiting condition. Pain relief will be via your USG and TENS modalities apart from your analgesics. Local steroid injections can be given to ease the pain. But stretching and strengthening exercises are again very important in this case because they are easy to perform at home and it helps in decreasing stiffness and pain over the heel. Some of the exercises are toe stretches, heel press, toe curl, calf raises to strengthen the calves, and plantar fascia stretch. These are very easy exercises that you can show them to the patient and ask them to do it day by day, and they should improve with time. Then you can also do taping of the foot. It aids only in temporary pain relief, but for the time being, you can do that until the patient gets better. Prescribe orthotics. What orthotics do is that they provide support to the arches of the foot. A lot of these patients with plantar fasciitis have flat foot, so they do require arch support footwear. And you can also prescribe them heel inserts or heel pads, which will provide cushioning for the heel and they can wear it with their regular footwear. When would you refer? If there is failure of conservative treatment, then you can refer them to a higher center. If there is a big calcaneal spur which requires to which require surgical excision, then you can refer them to a higher center. But most cases of plantar fasciitis do subside with conservative management. So, take-home point from today's class is that look at the patient as a whole. Clinical signs and symptoms are important, but it is important to elicit what is it about the disease that is actually bothering them, because then whatever treatment plan that you design will not be catered to the disease, but will be catered to the particular patient that you see in the OPD. Thank you.
So we've come to the end of our session. Thank you, Dr. Kiana and Dr. Jaya. It was a very extensive, actually it covered a lot of the points that we see quite commonly in our bonds. So thank you so much. So does anyone have any doubts that you would like to put up in the chat box or ask them? I think we will add both of you all to the bootcamp, the discussion group. So a lot of times when they come across cases that they see in their bond centers, they can put it up and you all can like answer their queries there as well. Kiana, you're muted.
Sorry, I think today was very didactic from our end, because I think it is very difficult to have a session where we're discussing cases that the bonders haven't seen. So if any of the bonders are keen, you can always bring up a case that you saw, and then we can discuss it, and we can like walk you through what you need to do. Even if it's a patient you saw, say, in the morning, and then you want to be able to follow them up, call them back the next day, and in the meantime we can always make a plan. And we're quite available, I think, as alumni. So I think I am also on the other group, on the academic group. I have shared a couple of the physiotherapy videos. The idea is not for you to show the videos to the patient, but for you to learn the exercises to show the patient. Because the patient, one Ajji in the middle of nowhere, is not going to use YouTube, I promise. So yeah, that should be from our end. And yeah, if any doubts, get in touch. Take home points, like Jaya mentioned, just know how to not have tunnel vision. Always look at the patient as a whole. Manage pain before asking someone to do an exercise, otherwise she'll kick you. And yeah, okay, cool. Well, thank you guys.
Thank you so much. And also everyone, we have put up feedback forms on the discussion group. I'll be putting up in the chat box as well. Please fill them. It is really helpful for us to plan future sessions, as well as to know like how we can improve on like our future sessions. So thank you everybody. Have a nice evening. Bye.
Thank you.
Angel, did you have a question?
No, sorry, ma'am. That was by mistake.
No, it's okay.
Yeah, yeah.
Okay. Thank you.
Thank you, ma'am. Yes, ma'am. Thank you, ma'am. Ma'am, also,
Yeah.
I just wanted to share the link of this to my other batch people, like in case they haven't joined via the last WhatsApp link. So in case if you can share the WhatsApp link to me, I'll just send you a hi on WhatsApp. Can you just share the WhatsApp link of the group to me, so I can share it to my people in final year also? Yeah.
Okay.
Yes,
Thank
ma'am.
you.
Thank you, ma'am. Yes, ma'am.